All right, hi everybody. So this is the rest of chapter 5. So we began with addiction, and now we are going to be transitioning into developmental disorders, followed by mental health, um, such as depression and anxiety. All right, so in terms of neuropsychiatric conditions and the content that we'll be covering in this class, one of the types of developmental disorders that we have is autism spectrum disorder. And and again, these are oftentimes being sort of revisited in terms of having these types of things on the spectrum, and largely that element is consistent with there being this spectrum of autism from low to higher functioning. It's characterized by difficulty with social interaction and communication, hypersensitivity to stimuli, repetitive behavior, the need for routines, and its diagnoses has increased dramatically, likely due to just the identification of it and being able to label it. There is some conception that this increase is due to other types of factors, such as vaccines, which is, a significant point of misinformation. As you can see here at the bottom, there is no evidence that vaccines contribute to autism development or symptoms. And the rise in autism is instead just likely due to being able to identify people on the spectrum more, increase in the effectiveness of diagnostic tests and things like that. But it's this highly repetitious, sort of like repetitive, structured, like you can see these elements of these themes: repetitive behavior, hypersensitivity, the need for routines, and social interactions and communications oftentimes fall out of these sort of routine elements where you need to be a little bit more impromptu. And that is particularly a space of heightened challenge. And the idea is that these repetitive behaviors and these needs for the repetitive behaviors can be an element of a coping mechanism for responding to sort of because you're hypersensitive to stimuli. And so those are sort of a result of that. And then may also, again, there's sort of behavioral sort of tics and things like that in terms of some repetitive behaviors that have neuropsychiatric origins as well. Possible causes and risk factors. Genetics is the top cause and the risk factor. It is a genetic, it's characterized by particular genetic combinations. There's other types of things that can have these types of effects, which would be exposure to heavy metals, pesticides, and herbicides. So lead, for example, heavy metals, things in drinking water, and pesticides and herbicides actually have some ingredients that can actually affect more of the nervous system in the sense of how they are trying, they work. That's part of a mechanism of how they work, to stop pests, but then it can have these very different and long-standing consequences. Pesticides and herbicides are actually something that need a lot more work and research because they don't have anything sort of like, oh, what's the downstream elements of these, of using these pesticides over a long period of time. Instead, there's just been observations where it's resulted in lots of potential risk. Bee colonies and sort of pollinators, all pollinators, but bee colonies and things that having the use of these pesticides and herbicides can cause not just sort of damage to the particular kind of generation of bug that is alive in that time, but also can remove them and remove species to prevent them sort of ever from being there. And for losing pollinators would would actually be pretty calamitous in terms of the functioning of our world. Other disorders, including Down syndrome, Fragile X syndrome, and PKU, are often those individuals are present on the autism spectrum. And as I stated before, there is no evidence that vaccines contribute to autism. So what is happening? Like what is the source of some of these differences in behaviors? And here's what we currently postulate. The one is, I guess, a sort of an overarching observation is that the nucleus accumbens reacts differently to rewards in individuals on the spectrum. And you can actually have overactivation of the amygdala and the prefrontal cortex. And this overactivation can make stimuli overwhelming. And so our amygdala is actually, as we talked about, is have our aspects of our sort of relevance detector. It's really involved in aspects of emotion, particularly fear, which you can have very sort of strong reactions to. So and that's a really evolutionarily important emotion to have. I mean, it's just really evolutionary important emotion, period. And so if you have overactivation of the amygdala, that means it's just going to respond to more and more things in the environment. And the prefrontal cortex typically can downregulate the amygdala. But if you have overactivation, again, in these particular ways, it can't necessarily do that. And which can create these overall problems in behavioral regulation. So consequently, the treatment is actually this applied behavioral analysis using associative learning methods to shape good behavior. And these are basically a lot of the types of things that would align, creating positive associations in children, again, to help with sort of these learned communicative and social skills. And this, but this is not something that's sort of widely available in terms of this is a treatment for autism, but behavioral analysis using associative learning methods to shape good behavior is probably actually something that many, many, many people would benefit from in terms of trying to engage in good habits and potentially correct bad habits. Unfortunately, there's not much medication for autism, but there's some research being conducted on particular substances that may offer some relief in this area. Current stuff is focusing on vasopressin and oxytocin, and both of those are both of those have particular developmental periods where those vasopressin and oxytocin, where they can have big impacts on the developing body. And oxytocin, for example, is one of the neurotransmitters that's associated with social functioning and bonding behaviors and things like that. So it's possible that shifts or areas where these neurotransmitters are also affected could be something that is a part of addressing autism spectrum disorder. All right, so moving on to other developmental disorders. ADHD, a very, very common one. So something that there's a bit more experience with, just in terms of the student population in general. So attention deficit hyperactivity disorder. This is basically difficulty with executive function, difficulty with focusing, pay attention, and regulating and controlling behavior. Individuals with ADHD also, in terms of that large sort of like behavioral regulation element, have issues with emotion and emotion regulation. And emotion regulation, many of those techniques are actually cognitive in nature. that involve using cognitive processes in specific and directed ways. And so with difficulty in that area, then emotion regulation is going to be something that's more difficult as well. And many adults with ADHD note it as a consistent problem or issue. Excuse me. Of course, I've been doing fine all day. Right when I start to lecture is when my allergies kick in. All right, so risks and causes. ADHD is actually diagnosed 3 times more frequently in boys than girls. And there are many that actually think this is due to an assessment error, that girls have just as much incidence of ADHD, except that it's not, it represents differently than boys. Goodness. And so therefore it's basically just underdiagnosed in girls. So that's something that diagnostic element is actually being examined, because there are ways that genders are likely to present differently for these sort of social reasons, in terms of like how the different stages in development for males versus females, and also just the fact that I'm sorry, all my coughing is actually just made me lose my concentration a little bit. So there's basically questioning with regards to the frequency of boys versus girls in terms of ADHD diagnoses. ADHD is more common in people with autism spectrum disorder and individuals with anxiety, epilepsy, and sleep disorders. So there's some, those commonalities definitely show some potential common underlying factors as well. And in terms of risks and causes, and the final element, genetics is obviously going to be a big causal factor, and potentially risks as well. Brain injury and exposure to chemicals, those are the types of things that could also give rise to ADHD symptoms. Excuse me. All right. And within the brain, you can have underactivation of the prefrontal cortex, and so makes it harder for it to regulate behavior. Underactivity in the parietal lobe, limbic system, and the striatum. And these are the areas that actually control attention and inhibit unwanted stimuli. So you can kind of see some of these effects, particularly as we're covering the autism spectrum and then moving into ADHD and what you know of the brain and the body right now. And the parietal lobe and the prefrontal cortex lobe, these are highly involved in attention, planning, control, and movement. ADHD is also linked with areas of the brain that are high in dopamine neurons. And so this suggests dopamine is really present for learning and reward learning, and aspects of attention. So this is very much in line with the symptom profile. And current treatments are psychostimulants that are dopamine agonists, like Ritalin and Adderall. But these are also being misused as, performance enhancing medication/drugs. So there's a lot of controversy in this space. All right, so now we are actually moving on to some of the mental health disorders. And so our first one is depression, which pretty much everybody is familiar with in some form, unfortunately. And So major depressive disorder is actually characterized by this inability to experience pleasure, which is known as anhedonia. So the idea that some of the things that you typically find as pleasurable are not as pleasurable, or lose aspects of all of their pleasure, in when someone is depressed. So, like, oh, which can make it harder to like use, elements of a person's environment or the things that they're interested in to sort of encourage motivation behavior, because they actually have this loss of pleasure. So it's this, you can have a real loss of motivational capacity. You can see this here, in terms of just other ways. Um, Depression associated with high hopelessness, helplessness, and feelings of worthlessness. And it is and these can also be sort of related to potentially these sort of low, positivity states, so that without some of these things, then it's really hard to balance and you feel hopeless, worthless, and helpless. This is also a common disorder, and it's twice as likely in women than men, but this may also be related to sampling, um, because men are significantly less likely to come forward with symptoms of depression. They can oftentimes males can represent differently in terms of depression. And males are more likely to have a form of depression that is also characterized by anger responses, and they can be known as sort of angry depressives, which are actually really, really hard to do research on. Most research on these spaces happens in universities, which are staffed with students and trainees, and at all various levels: doctoral trainees, postdoctoral trainees, masters, undergraduate. And it's actually really hard to have them come in to do research on angry depressives, because it can place the people running the experiments or sort of running the research projects um, in sort of this not quite as safe space of, you're dealing with someone who can kind of like erupt into these anger elements. And so it's likely that, there's the sampling errors are leading or especially contributing to the differences in the incidence of depression between males and females. There's also issues with sleep, sex drive, and appetite. These can all be affected by major depressive disorder. Um, Sex drive can drop precipitously, particularly in females, which can also, contribute to depression, affecting aspects of relationships, partners, where those types of behaviors are important. Sleep is, you can have start to develop insomnia during depression, which is going to make depression symptoms worse. And depression is linked to anxiety disorders, substance use, cardiovascular disease, and suicide. So definitely have sort of all of these spaces as negative outputs. So it's really, really important to pay attention to and work on understanding more. And common treatments for depression basically shift based on some of the theories with regards to depression etiology. I'm going to go ahead and, okay, just checking. So you can see here we have, we'll go into a couple of slides coming up. And so one of the hypotheses is that you have this monoamine hypothesis, and in which there are chronically lower levels of monoamines, especially serotonin and neuroepinephrine. And so and these monoamines these are particular amino acids and things that are also going to be really helpful for producing neurotransmitters. And so antidepressants are monoamine agonists, which means they'll try to go ahead and increase the power of these monoamine the monoamines that a person has in terms of their serotonin and norepinephrine are low, then medication is going to try to basically make those be able to work more by keeping it, by basically helping those areas activate. Relatedly, then you have monoamine oxidase inhibitors. This is decreased activity of monoamine oxidase, an enzyme that breaks up monoamines. And this can then increase monoamine activity in the synapse. So these, again, this is a different type of treatment in the sense that these medications, they typically you have monoamine oxidase MOIs that break up these monoamines, so they would be breaking up the serotonin and the norepinephrine so that they are being removed from the synapse. So this particular medication, monoamine oxidase inhibitors, which is, again, these are classes, this is a class of medications, then that can decrease the level of monoamine oxidase, which breaks those things up, and therefore increase activity of serotonin and norepinephrine, for example, in the synapse. I always thought this was kind of interesting that there's this noted cheese reaction with individuals taking MAOIs, and this is kind of a side effect of eating certain foods like cheeses, meats, and red wine, which can cause high blood pressure. So there is a so certain types of foods and everything can interact with MAOI. So you want to be paying attention to diet in that way. Then you also have tricyclic antidepressants. These are another class of medications that are serotonin and norepinephrine reuptake inhibitors. So they are not as used quite as often today because they can actually be fatal at high doses. So these typically aren't prescribed quite as much. But then you have ones that are, these are much more commonly prescribed, selective serotonin reuptake inhibitors. So this is actually the most common class of antidepressant medications. It keeps serotonin in the synapse, so similar types of things as the prior ones do, by stopping, again, the reuptake of that of that neurotransmitter in the synapse. It may also restructure transporters and G proteins in the membrane, and that might that'll have some of these downstream effects. And common brands include Prozac, Zoloft, and Paxil. Then you also have norepinephrine reuptake inhibitors, SNRIs, and this keeps norepinephrine in the synapse longer. So again, they've noticed the serotonin and the norepinephrine as being associated with depression. So they have medications that are treating both of these areas. So these types of medications can also take a long time to work, and unfortunately do not work at all, like for all patients, which can be particularly challenging because depression is really common and it can be quite hard to treat. So, and typically the ideal space is that there isn't really much of an understanding that medication would be able to treat these alone. They would largely be a combination of treatments, in which case you'll have medication and particular forms of therapy that can help adjust some of the cognitive the cognitive processes or the thought patterns that are associated with depression to help increase coping and emotion regulation skills to mitigate against those the depression symptoms. So one of them is known as cognitive behavioral therapy. This is very common, and this is where people learn to recognize and replace the negative thoughts or behaviors that contribute to depression. And as I said, medication and CBT are basically some of the most effective treatment combinations. They're always going to be trying to go for both of those. Then you have, these are some alternative treatments: electroconvulsive therapy, ECT. Patient is given an anesthetic and muscle relaxants. Electricity is run through the brain, and patients do not remember the procedure because electricity is running through the brain. And so it's disrupting all of that, which can honestly sound kind of scary. This is an invasive treatment, but patients don't remember the procedure, and it can actually be effective for a fast release of depression symptoms, and tends to be used when normal medications aren't working. And then with continuing on with alternative treatments, you also have direct current stimulation. And this would be where direct current in an electrode is actually in your brain. So you would plant this little electrode at a particular key spot that there are a couple in this sort of prefrontal cortex area. Some of them are internal. They would basically put this in sort of electrode here, and then bring about this direct current. And it's basically, actually, excuse me, this is not, the deep brain stimulation is sort of the electrodes. The direct, which I was just thinking about both at the same time. The direct current stimulation is actually like a form of a modified form of the ECT, where you actually have these, instead of having it go through your whole head, you have these sort of like a machine here that would basically, through direct current stimulation, and then it would basically try to treat, like through stimulation, address those particular areas. And it's not quite as invasive as the ECT and its effects, and it's also just more effective for mild forms of depression. And the idea of these ECT, or sort of these stimulation treatments, is just this kind of resetting effect of that. It's like going through and kind of flushing with our sort of synapses with electrical, with electricity, to kind of flush our synapses, so to speak, and to basically cause sort of like a rapid shift in potentially some of the neuronal pathways that are being used most often. And so through this ECT, or through these direct stimulation methods, then you can basically cause these sort of cascading changes due to kind of flushing out your system. Then you can also have deep brain stimulation, which is, of course, very invasive. And this is when electrodes are implanted into the brain at areas of the cingulate cortex, which is the one I was speaking about earlier. It's sort of like deeper inside. And sort of, or the medial forebrain. Again, the forebrain is this sort of area right here, and medial is the middle. So it's stuff that basically is right smack in the middle here, but a little bit more back into your head. And the level of electricity is controllable. And this is used predominantly when other treatments fail for major depressive disorder. It has mixed results, with some people finding it really beneficial and some not, which would be understandable given, that's the way it is with most treatment modalities. But it's basically postulated to address sort of, again, this sort of chronic sort of space here. The deep brain stimulation might occur for, I'm not actually sure of the length of time, but unfortunately, but then it's in this particular spot. So it's going to, again, so that causing electrical sort of like firing in this space is going to have these sort of cascading downstream effects. And it has been purported by some to basically be so helpful that's like they're in this kind of deep trench of depression, and they can't even sort of like get up enough to the sides to kind of use some of their skills and stuff like that. And so So this is basically this idea that, and maybe this is part of the reason that the results are mixed, because it doesn't necessarily cure, or again, like how effective is it is for treatment, but it can help you rise from this really intractable space where you have been like treatment resistant to actually making treatment a bit more effective. So so basically all of these would be, figured out for a person on a case-by-case basis. Our next affective disorder is bipolar disorder. And it was known just sort of as, like bipolar disorder, but now that, again, with these sort of expanded descriptions, bipolar affective disorder. And this involves basically going back and forth between highs and lows. And so this would be involved with depression, with bouts of mania. Now, mania, like this may sound like a cool sort of space, but it's noted by extreme energy, irrational behaviors such as starting big projects or spending lots of money, and irrational thoughts, delusions, and sometimes hallucinations. And so, like going on a manic episode can cause someone to go on a spending spree, all these types of things that can actually have these, real downstream negative, consequences and behaviorally. Then you can also have hypomania, which is similar to mania, but it's less extreme, few irrational thoughts and behaviors, and you're more functional. So basically, you can have bipolar disorder, you have your depression, but then the mania can be full-on mania, or it can be hypomania, which is less, again, which is less extreme. And so you're not getting again, full into that super activated manic state. So in terms of sort of breaking this down, they've separated these as sort of as different parts of the disorder, potentially even, again, different types of disorders. So bipolar 1 is the latter top one. It has depression and the high end mania. So here you have like a really high risk of suicide or self-injury. In terms of getting back to this manic state that they're noting right here, the manic states can be associated with like grandiose thinking and like thinking you're invincible and things like that. And so, and then, or like transferring from a depressive episode to a manic episode where you're still basically really depressed, but you're kind of coming out into this manic space. That can actually be really hard because that's at a place where you're having a higher risk of suicide. And then you have bipolar 2, which has the depression and hypomania. So the mania is not quite as severe. And this is noted as sort of more functional than bipolar 1. You can also have, for example, different kind of characteristics of this. So you can have like rapid cycling bipolar 2, which is how long the cycle is of sort of this depression or sort of hypomania. So for bipolar 1, you can have a depression episode last like months, and then you could have the manic stuff come in. And oftentimes the medication is going to help you, help you during the depressed period. And then what happens is people like, oh, I don't think I need this anymore. When they get into the manic space, they stop taking their meds and they can sort of go into this sort of spiral of problems. And but those have a time scale of where the episodes of depression and mania, the episodes of depression are pretty much always longer, but in general, the cycles are longer. For bipolar 2, those cycles can be shorter. So again, they can, instead of months, they might be on sort of like days or maybe even sort of weeks, and you have it more functional. But and you can also have those cycles that would happen really quickly. So you could have rapid cycling bipolar 2, which would mean that you're going to cycle through kind of depression and hypomania potentially within the same day or multiple times within that day. And so treatments for this are mood stabilizing drugs like lithium carbonate and therapy. And many bipolar 1, many depressive medications work. And so usually there's just a combination of medications that you would need to find out. We also have anxiety and stress disorders. So our generalized anxiety disorder, GAD, this is very, very common. And I think even more so now, post-pandemic, or even during pandemic and post-pandemic. GAD is associated with persistent worry and stress, nausea, headaches, muscle tension, and tremors. So this continued anxiety, anxious, stress state can have chronic effects on your body. And that's some of the stuff that you might see in terms of this nausea, headaches, muscle tension, and tremors. This affects 3% of the population with like full on generalized anxiety disorder. But I think I'm pretty confident that that rate has increased. It's characterized by overactivation of the HPA axis and the limbic system. So if you have overactivation of your HP axis, we just went over that in terms of stress, that your HP axis basically responds to stress, and in terms of the fight or flight elements. And if you have overreaction of this, it's going to kind of stay in this heightened state, which is going to make it much more difficult to use your sort of parasympathetic nervous system to calm yourself. And structurally, this is represented by underactivation of the connection between the dorsolateral prefrontal cortex, cingulate cortex, and the amygdala. Thinking about these areas that are involved, the amygdala is going to respond to stimuli, and it's again particularly responsive to fearful stimuli. And there's a lot of sort of fear and anxiety that are sort of basically very related. And so you can see how this hyperactivation of this amygdala would make it harder for cingulate cortex and the dorsolateral prefrontal cortex to downregulate some of that heightened activity. It's associated with higher levels of cortisol, which again is linked with the HP axis in terms of overactivation. And it's influenced by genetics, so you can have a genetic predisposition, and trauma life events are highly significant predictors. So usually there's some elements of trauma, or at varying levels that are associated with generalized anxiety disorder. Closely related are phobia kind of anxiety disorders, are just generally known as phobias. And these are irrational fear and extreme stress responses to objects or situations. So again, this overactivity of your HPA axis in terms of like, being really activated and put into this sort of fearful, anxious state. Common ones are arachnophobia, fear of spiders, acrophobia, fear of heights, cowlrophobia, fear of clowns, agoraphobia, fear of open or public spaces. And so you have these different types. So and generally, except for the clowns, then some of these are like spiders, we're much more likely to have a natural predisposition because evolutionarily, like they can be associated with like negative outcomes. Arachnophobia, acrophobia in terms of fear of heights, that's honestly, sort of like if you're afraid of heights, then you're not going to be putting yourself in a dangerous situation where you could fall. But acrophobia is going to be like a significant fear above that, and that you would have this irrational fear of heights. And then but all of these and phobias, and all phobias basically share these sort of common core sort of fear, anxious, anxiety elements. And just as we've covered that based on the role of the amygdala and what we know about learning, that these phobias are likely related to, again, classical fear conditioning responses, where you're learning the association that like some type of event or object or situation, be it spiders or heights, is associated with fear. And typically that would be mediated by the amygdala in the hippocampus. And it doesn't seem to be happening basically in the way that you would expect. And that the amygdala is responding, a great deal to these instead of habituating. So there's sort of this sensitization process that may be occurring. Continuing with this, you have panic disorder. This would be sudden, or continuing on with our anxiety disorders and stress disorders. We have panic disorder and sudden feelings of fears and stress. So this is associated with a panic attack. And this panic disorder, these panic attacks can again occur with the generalized anxiety and any of the phobias, and can obviously make all of those work. It's an overreaction of the sympathetic nervous system. So going into the sort of hyperdrive sort of element for fight or flight, stuff like that. Or the fear response can also just be freeze. So it's this overreaction of the system and overreaction of the amygdala and the nearby periodactyl gray. This again, showing this hyperactivity makes it much harder to sort of downregulate these elements. And if you have a panic attack, it can basically strengthen the classical conditioning sort of response, here, in terms of that in itself. The panic attacks are very scary. So, and you can like get yourself into that space by talking, talking to yourself, and you can like, it's your own thinking, like if you get there and like really think about it and zero in and use sort of rumination, and it's negative thinking and things like that, if you get caught in these sort of ruminative loops, and it gets sort of deeper and deeper, then those types of things can also activate panic attacks. And suggested that this panic attacks could be a product of pH imbalance in the brain. And just taking a look at what we have next. So we are at obsessive compulsive disorder. And these are frequent uncontrollable anxiety-provoking thoughts, obsessions, repetitive or ritualistic behavior. These are compulsions. This can increasing all these sort of checking points of routine, hand washing, checking locks, counting. And this is also associated with increased areas of activity in the frontal cortex and the cingulate cortex and areas of the basal ganglia. This has many possible causes, including genetics. Symptoms also arise from certain infections, such as Sydenham's chorea and pediatric autoimmune neuropsychiatric disorders, which are associated with streptococcal infections. So, so it's possible that again, you can see some of these origin spaces and see some of the similarities across these disorders of these common areas. And we have post-traumatic stress disorder. This is basically trauma stress, that from this extremely significant stressful event. These can be natural disasters, prolonged abuse, sexual or personal assault, military combat, any like war zones, thinking about all the different things that we have going on in the world right now. There's lots of potential for trauma. PTSD is associated with problems with sleep, memory, intrusive thoughts, or flashbacks of the traumatic event. And this can lead to self-destructive behavior, including addiction, linked to depression, and it has a strong correlation with traumatic brain injury. So you can, because particularly like if you are in this traumatic situation and your body is impacted, that oftentimes means, your head would be impacted. So you can have, traumatic brain injury is actually really, really common with PTSD. And it's postulated that a mechanism is going to be lower cortisol responses to stressors. And so you might then be trying to work to increase cortisol responsivity in individuals with PTSD. Now, treatments for these range of anxiety disorders includes anxiolytics, anti-anxiety medications to reduce anxiety, benzodiazepines. These are really prescribed with great caution, and they're highly prescribed. They're GABA agonists, so they would help sort of facilitate these inhibitory elements in the brain. There's a strong risk of dependence and addiction with benzodiazepines, and stopping, when you stop them, can actually rebound to this heightened state of anxiety. And antidepressants are also really commonly prescribed for anxiety disorders. And this brings us basically to the end of this chapter. And so I hope you have enjoyed some of this content. Sorry, I got off to a little bit of a rough start. It can take a little bit to just kind of get into this lecturing to a computer space. So good luck with studying for chapter 15, and have a great day.